Let us begin. I'm Judith Richards. I'm the creator of the Richards Trauma Process. Welcome. Thank you for investing your time, investing your energy in joining us this afternoon Australia time. Let me introduce these other panelists today. We have with us Dr. Dinah Blunt. Dinah is an anaesthetist, a specialist anaesthetist, medical doctor working in Brisbane. Dinah has a particular interest in, she's worked a lot for many years in pain clinics. She has a lot of experience there that we'll be digging into as we speak, as we have this conversation. And Dinah's also got an interest in awareness under anaesthesia. That'd be a little bit traumatic, wouldn't it?
Yeah, about as big as it comes as far as medical trauma is concerned. Absolutely. And birth trauma is another interest of mine, obstetric.
I didn't know that. I did not know that. This is excellent. We will talk about that.
Yes, I know there's a few other people who are interested in doing
okay, I'm making a note. Birth trauma. It's not really totally on topic, but it is on topic. Let's do it. It's worth doing.
Absolutely.
May I introduce to you Carole Young. Carole's in the Blue Mountains in New South Wales. Carole is a physiotherapist with many years' experience in the rehab area, working in work cover, etc. So welcome, Carole. Great to have you here.
Thank you.
All right. Yes, Karen Morley, very interested in birth trauma. Great. Yes. Margaret worked with people recovering from birth trauma for many years. Okay. We're definitely going to have that conversation. So let's begin. This is not a webinar about TRTP. If you are interested in finding out more about TRTP, you can find out more at therichards.traumaprocess.com. therichards.traumaprocess.com. Don't go there yet. Stay here. It's going to be a fabulous conversation. All right, let us talk about pain, the trauma implications in chronic pain, and the often associated depression, anxiety, and PTSD. How do we resolve the trauma? How do we resolve the pain? Isn't that a fabulous topic? Let's get into it. It's nice and meaty.
It's a huge topic. Yeah,
it is. And
how long have we got?
Yeah. Well, we're going to talk for about 35 minutes, 40 minutes, and then we'll take questions unless we have. Please feel free, people who are here, to type in questions as we go along, and that will direct our conversation. Let's just talk about largely there's two areas of physical pain. Now, Dinah, you can correct me on this, and Carole, if I need correction, but there's the pain there's a pain for a reason, an ongoing reason. For example, rheumatoid arthritis. I mean, hello?
Yeah.
Dreadful pain. Then there's pain from an injury that is healed, but there's still pain. It's real pain. It's not pretend. It's not just someone making up that they have pain. But the doctors, the medical teams say there's no reason. The body is healed, and there is no reason now for that person to have so much pain. This can blow out into chronic regional pain syndrome. Let's begin with the pain where the body is healed. The body should not be experiencing pain. Let's start with that. Dinah.
Yeah, look, I mean, that side of things, I mean, it's the real crux of the type of patients that we see in the chronic pain clinic, where you've got somebody who certainly has had a painful condition in the past that is now healed, but they have persisting pain, and chronic pain is loosely defined as pain that's persisting longer than about 3 months after an original injury. And what seems to happen is that the body has for some reason, decided to continue behaving in that way. And there may be inflammatory markers, there may be things going on like that, but it's way out of proportion to any known pathology, any demonstrable pathology.
Yeah.
And at that stage, of course, the role of the patient's own psyche, their coping mechanisms, their past history of painful conditions in the past, and also, you know, whether they tend to have anxiety or depression for other reasons as well, will all come in together, plus their social situation, plus sometimes isolation, plus sometimes things like compensation or litigation that's ongoing, and things like this can all come in to create a situation where, for perhaps sometimes unconscious beliefs, unconscious reasons, that pain has to continue. And then you've got to start unraveling what the various components of that are.
Right. And often, for example, I was talking with Carole about this earlier today, that with chronic regional pain syndrome, there's often a very strong connection to people who've had a lot of distress in the past, otherwise known as trauma.
Yes.
So people who've already been traumatized are more prone to present with chronic regional pain syndrome.
Yep.
So in terms of how the model that we use in resolving this type of pain, I'll go into that in just a moment. Carole, do you have anything to add on that?
Oh, look, I totally agree with what Dinah's saying, and I always often say to my patients that pain and tissue damage, they very rarely relate directly. So where you feel you've got tissue damage and you've got pain, they may or may not be related. So and I tend to try right from the beginning to talk about the pain in different words as more as a discomfort or a sensation, so that we start the brain disconnecting from the idea that it's pain. It's just it's a sensation they're experiencing that's a learned memory of discomfort.
Let's explore that learned memory just a moment. Thank you, Carole. That's great. Hello, Manon. You're here now. We will talk about migraine as well. So what Carole just said then, the memory, let's take that apart. The model that we use in TRTP is that at the time of a distressing event, and so Carole, lots of the people that you see would have had accidents, and you too, Dinah, and Dinah more particularly with
as a physio, I would get quite different referrals than Dinah for different reasons, but I suspect we all end up playing in the same pond with the patient.
So for whatever the distressing event that originally caused the pain, whether it was surgical, medical, or accident, what happens at the time of that distressing event is the body releases stress hormones, you know, adrenaline, etc. Of course we do. But what can happen is that we flood with the stress hormones, and the hippocampus shut down, and the hippocampus is responsible for taking that event and putting it in long-term memory and shutting the door. It's over. But what actually happens instead, because it's not doing its job, it's the librarian and it's on strike, and what happens is that event gets stored as a videotape loop in the unconscious, as if it's happening now. It's happening now. So basically, in our unconscious, we're stuck in Groundhog Day, re-experiencing that event. And the unconscious runs every chemical reaction, every electrical response in the body. Thank goodness it does, and we don't have to keep our heart beating consciously. And so the body is responding as if, you know, I'm being cut out of the car now, I think I'm dying, or whatever it is. So the body is in this hyper-aroused state of I'm in danger, I'm not safe, I'm not safe. Consciously, we're not aware that this is going on. We just experience the physicality of that hyper-aroused state and the hypervigilance, etc. It does break through into the conscious mind. These videotape loops break through into the conscious mind in the arena of extreme PTSD. It breaks through into the conscious mind in flashbacks.
Flashbacks, yeah.
Which are relived experiences. It's not just a memory. You actually relive it as if it's happening now. Hello?
Mm.
And it's the same for lesser states of anxiety. People are stuck in that, and sometimes people go into the shutdown, freeze state of depression. But it's all the same reason. It's happening now, it's happening now. So somebody can have a horrific accident. I had one woman who had extensive damage to her spine in a car accident. Her spine was very full of various hardwares, but the doctors were saying there was no reason for her to be bedridden in pain. So what did we do to stop it? Very simple. We turned off those videotape loops. It's not happening. And we spoke directly to the unconscious. It's over and I'm safe now. And every part of her that had anything to do with that event then returned to calm. And the symptom, which was pain, depression, etc., the symptoms just disappeared. Because let's look at anxiety. It's a symptom. This pain that's ongoing, that has no physical reason anymore, it's a symptom of these videotape loops with the whole being screaming, I'm not safe, it's happening now.
Mm-hmm. Mm-hmm. With that tenet that, you know, the body does not differentiate between what is real and what is imagined. It's just acting on what the unconscious is giving it. And if the unconscious is pumping out the adrenaline and playing the videos, then the body is going to react the way the body's going to react. We are built for survival. And that involves this huge adrenaline outpouring and this fight, flight, fear response. And if the unconscious has played this thing and said, this is happening now, then the body is going to go with that absolutely every time. And it's real. It's real. It's absolutely real.
Very, very, very real pain.
Yeah.
You're right there, Carole.
She just fallen off her chair.
I just kicked the connection under my computer.
Oh, I thought you were going to say kick the cat. Okay, good.
All right.
I'm back.
Oh, good. Good. Thank you for that. So have you got anything more to say about those videos playing in the unconscious, that as if it's happening now, Carole?
Look, I think that pain is definitely the way that the physio profession has been taught, and I think that they haven't quite taken the leap in my understanding of attending all the pain conferences around, you know, what's the current understanding of the way a physiotherapist would treat pain, is that we understand that is a balance between what the body perceives as danger or safety. And that then leads me into going, well, if that's the case, then what is it in the body that might have previously been there that's primed to think that we're constantly in danger? And then that, of course, requires you to do a trauma history. So the difference between the way I would approach someone who comes to me with chronic pain is to, after doing an initial sort of chat and assessment, so have a look at what their trauma history is, and that then just makes it so clear what the way in. It makes it obvious, yeah. And that's the difference, I think, in the way that I work compared to your traditional ways that physios work. So I typically wouldn't do any of the usual sort of hands-on, you know, approach to treatment. Most of my 90% of my work is verbally talking. There is an element of hands-on work that I do that's an adjunct to calming the central nervous system. When someone's not available straight away to do the trauma work, they need to be safe and calmed and step them down. And there's techniques you can do to flood the central nervous system with confusing signals around the body that then resets the brain, because the brain's bioplastic. So what we're doing is it's a sensory technique that I use to start with, and then that allows people to go discharge a lot of the tension, and that then allows me to work with them at a greater level of engagement, if you will. Yeah.
Yeah.
That's the first step. Yeah.
Right. And then they're more ready for TRTP.
Yeah. Yeah, that's right. Because they get confused. They come, why do I need trauma therapy?
Yeah.
Hello, I've got a pain in my neck.
Exactly. Yeah.
I think the thing that you're leading onto there is this idea of bridging to the patient's expectations. So if the patient's been sent along to see a physio, then they're expecting physiotherapy,
Exactly.
and you've got to kind of go out and meet them there where they're expecting.
That's right, Dinah. Yeah, yeah. So
and then say
hands-on therapy. Yeah,
absolutely.
Yes.
And the other thing that you're sort of leading into as well is something that Judith and I were talking about last time, which is this idea that when you have somebody who is so consumed with pain, that the pain, your brain involvement in processing pain and complaining about pain and the whole behavior that comes from the pain is starting to take over such a huge amount of the brain that they're now unable to use some of their other sensory functions, some of their other cognitive functions. You'll find people who are in severe pain who cannot think straight, they can't see, they can't hear. Yeah. And what you're doing with saying, okay, we're going to use some physical therapy is then flooding that and saying, well, let's bring some physical stuff in to occupy the brain and try to start pushing this pain out of the way, so the part that the pain's taking over is getting less, and that's also part of what we do. And
it's also a technique to bring them into their body and out of their head.
Yes.
And if you can get them connecting with their breathing, that's also very powerful. Just because the vagus nerve system, you just want to
absolutely
get the vagal nerve system calmed, breathing, touch, all of that. They think they've had a physiotherapy sort of session, but they're suddenly going, oh, the pain lessens. There's no question about that.
Yeah.
But that pain will hang on there, like a parasite on a body until the key, that trigger, the trauma trigger, has been identified and switched off, and then the pain is not an issue.
Yeah.
But that takes. But then pain programs, they're not only they really expensive for patients, and I'm coming from my background in workers' comp and 35 years as a rehab provider, and the reason I'm here today actually, and Judith, is because my concern about the costs of anxiety, depression, PTSD in the workers' comp system, and very little really effective treatment for it, apart from long, drawn out, months, if not years of psych therapy, a bit of cognitive behavioural therapy. And I just thought there's got to be a better way.
What were some of those stats you were telling me, Carole? What were some of those stats?
Yeah, well, the average mental health claim for stress and bullying and harassment at work are some of the most common causes. But if you're bullied and harassed at work, you don't collapse into a full-blown mental health claim unless you're primed, unless you've got some predisposing, issues that it's like the tip of the iceberg. But the average sort of claim across all claims is $9,000, but for a mental health claim it's $26,000. And so you've got to think, if you even spend 1% of that, at one consultation, or 10% of that on a series of treatment, it's got to be better than what we've already got. Which
is a lot of money.
Absolutely. That's a lot of money.
That's a lot of money. And Carole was talking about the predisposal there, the predisposition to
collapsing.
Let's just talk about that. So the distress of life builds up like the pressure in a balloon. So there's that videotape loop and that one and that one and that one, and they're all running, big ones and little ones, and that distress builds up like the pressure in a balloon. And it can be the straw that breaks the camel's back, or a major disastrous catastrophic accident, or Black Saturday.
And you may not be necessarily aware that this stuff is building up underneath.
You're not aware at all.
And then you're functioning, you're
it's
working.
All in the unconscious, consciously.
It's all running along the unconscious. Yep.
And you can be fine, but then it can be the straw that breaks the camel's back, or something big, and we blow out into anxiety, depression, chronic regional pain syndrome, chronic fatigue, fibromyalgia, lupus. Something's got to give. There's so much pressure, something has to give. And for people with PTSD, they've shown that there's already a lot of distressing events in the past. And then there's the next one. And, you can have two twins go to war. They have similar experiences, and one will come home with PTSD and one won't, because that one that's come home with PTSD, there was already too much pressure there and it just blew out. So that's what happens. And that's the predisposition. Those figures are horrendous, up to $26,000 mental health issues. That's what they expect with work cover.
Plus, anyone who's got depression takes 20 times more days off work than someone who hasn't. So it's just lost time. I mean, that's just, there's lost time as well. So and then you get the physicality of all of that. I mean, the comorbidities with PTSD, with gut problems, headache, everything else, and the whole system starts to break down, of course.
And then they're in that spiral.
And there's it's all downhill from there.
Can I just
before you go further, Carole, can I just say that I neglected to state at the beginning of this webinar that Dinah and Carole have both come to TRTP to learn how to relieve
chronic
all
pain.
of this. Chronic pain, depression, anxiety.
Chronic pain, anxiety,
and trauma.
Phobias, trauma,
all of that, and have found, well, how have you found it, Dinah?
I've found it extraordinary. I mean, you see quite remarkable changes in patients. I don't do anything with my pain patients. I don't do the drugs and the blocks and the classical techniques anymore at all. I only do TRTP.
That's
because
huge.
there is always something.
You don't use the pharmaceuticals.
No, I'm not interested.
TRTP.
There's plenty of other people doing that.
Well,
and a lot of the patients who come to see me have been through all of that.
Yes,
and they know that it doesn't work. And they've heard that there is an alternative.
It's been proven that
absolutely those things don't work, and that's why I stopped working actually in the pain clinic. Absolutely,
it's a big con, basically.
Disastrous. It's just rubbish. Absolute rubbish.
And Carole, you came.
So there was a couple of questions just came up asking me a bit about the sensory technique, and I thought I'd just mention that. It's a technique that is it's called the associative awareness technique, which in my mind is a beautiful adjunct to what I do with TRTP. And it came from a group of physios in America doing chronic pain and trauma work. I haven't found a group in Australia yet doing quite the same, going in the same area. I think it's a new frontier for physios, but you have to have a particular interest in it. If you told me I'd be working in the field of chronic pain 5 years ago, I would have said, shoot me now. I'm not interested in that field. But because I have tools now, I think, I can do something here, and it's really making a difference. So the associative awareness technique is
can we send people to look that up on the website?
Well, associative awareness technique. Yes, you can Google it. It's a very gentle technique of touching the arms, the legs, the shoulders, the face, in a particular way that confuses and calms.
Is that similar to havening?
No, not really. No, I wouldn't say so. No.
Okay. All right. Good. No. Thank you for clarifying.
It has a similar outcome, but it isn't a similar technique.
Yeah.
All right.
Yeah.
And so that's to get people to a calmer place so that they can actually fully engage in the TRTP.
So that you can just relate to them. You can start meeting them where they need to be met because they're already gone, I feel better already. And this is just the beginning. So, it's building trust and just small gains to start with, because I can't say, okay, we're going to do trauma therapy now. Or I can actually, with some clients, they go, fantastic, this sounds like just what I need. But others a bit more.
You have to build up to it. Lead them along. Take them by the hand and lead them along.
And the GP needs to understand what we're doing as well when the GP's referred people for physio.
Yeah.
Right. Traditional healing hands.
It's an education both ways. Yeah.
So Peter's asking, I've heard about the TRTP program. Could I give a description of what is involved if we're talking to a patient about it? Well, it's basically what I just said about we have the distressing event, hippocampus gets overwhelmed with the stress hormones and doesn't do its job. And so the distressing event is continually experienced as if it's happening now in the unconscious, like a videotape loop in the unconscious. And that builds up, that event and that event and that event. Pressure builds up in the balloon as we go through life, and then we can blow out into anxiety, depression, fibromyalgia, chronic regional pain syndrome, PTSD, whatever it is that we're going to go into. And it's very simple to turn off all those symptoms. Chronic fatigue is a symptom, fibromyalgia is a symptom, chronic regional pain syndrome is a symptom, anxiety, depression, PTSD, they're all symptoms of the whole being screaming, I'm not safe. Why? Because of, I think the technical term is shit that's happened, that's never been stored properly. So all we have to do is turn off those videotape loops and tell the unconscious and the body, hey, stop it. It's over and you're safe now. That has passed. And the hippocampus, it's like doing a factory reboot on a phone. And the hippocampus goes, oh, okay, and puts all the memories to bed, closes the door. And we say to a client, even the most traumatized clients, what some people go through is just horrendous. But we can say to them, hand on heart, if you fully engage in this, because it's part of the cure to wish to be cured, hello, Seneca, the great philosopher, said that over 2,000 years ago. If you fully engage in this program, that by the end of the third session, because it's only 3 sessions, let's point that out, it's 3 sessions, very rarely it's 4.
That's why it's so cost effective.
That's why it's so cost effective.
Absolutely.
It's fast, it's effective, it's safe, nobody's re-traumatized.
Yep.
And it's long lasting. I've followed some clients for 7 years now. And so we can say to them, hand on heart, it's, by the end of the 3rd session, you'll be able to talk about what happened to you. You'll be able to think about what happened to you, and it'll just be boring. There'll be no emotional charge there at all.
It's like a 10-year-old shopping list that you just found.
Yep. Coffee, rice.
Yes, that's right.
Tea.
Yeah.
It'll just be as boring as that. And a lot of people say, oh, I can't imagine that. So you don't have to, you'll just see. And people at the end go, it's right. It's just, I don't care anymore. And with the pain, and the pain has gone. It does other things like, but anyway, would you like to add anything to that, Carole?
I think we need to just keep telling people how bioplastic the brain is.
Yes.
It's not hocus pocus here. What we're doing is, and I know that, say fibromyalgia, for example, there's a lot of research now that shows you that the brain of a person with fibromyalgia has a lot of inflammation in certain areas. And what we're doing is changing the firing of the brain to calm and to change the messaging and the signaling that's going into the brain that calms it down, and that it sort of switches the system, and we can. I'm not don't want to go into too much biochemistry here, but what we do is we bring in some of the kind of brain soup, some of the different chemicals in the brain that come in and surround, and it literally kind of eat up or they can actually eat up some of those chemicals that are causing the inflammation, and you can see this. Process happening in proper electron microscopes and under CT scans and things. So it's the beginning of a very interesting, exciting field, and we're just beginning to understand it a bit more. But it's not that the pain is all in your mind. There are changes that happen in the brain.
Yes, and it's interesting.
And it's therefore able to be changed through bioplasticity, yeah.
And it's interesting that so many of the clients that we see, and I've seen many hundreds, that there's for so many, there's instant Jesus moments. I mean, you can see somebody who can who's contracted in pain, just where's it gone? I had one woman who could hardly move and was about to commit suicide. She said, I have the means in hand to take my life. I can't do this pain anymore, but my husband's not quite ready. Can you help me to reduce my pain by 5%? I said, 5%? Why? And she said, because then I can stand to stay another few weeks to get him ready for my suicide. But if you can't help me, if you can't reduce my pain by 5%, I will suicide tonight. I thought, well, no pressure. But by the end of that first session, she was running around the car park and touching her toes and moving it and yelling, Barry, it's gone, Barry, it's gone. And these Jesus moments are very regular occurrences. It's extraordinary how it happens so quickly. And just in terms of all the inflammation in the body, I have a theory on that, that the unconscious is screaming, I'm not safe. So we are hyper vigilant. Where's the danger? Where's the danger? Yep. And the body can't make any logical good sense out of it. So it goes, it's this part of the body. Or it's a general inflammatory response. Or it's that food. And all of a sudden we are really reactive to foods, chemicals, etc. Because the body's going, there's the enemy, there's the danger. And it's this crazy system gone nuts. And when everything calms down, and it can happen like that, sounds crazy, doesn't it? But that's what happens. I mean, we see it all the time, and the inflammation just disappears.
It's a bit like if you say somebody who's very stressed out, and they're in a bit of a stressed out, bad mood. They're very irritable. And you can see them, they'll snap at people. And this is what the body's doing. The body is in this state of irritability and is snapping at everything, anything that it can find, and producing this inflammation all over the place. And once you realize that that's all being run subconsciously, and that we can get to the subconscious using these techniques and tell it, no, that was old.
It's over.
It's over. Everything's safe.
Now. And some people on this call have Faye Triantis, my resentment, my brother melted like magic. Yeah. Yes, and that's what we would expect. If people on the call, if you just say out loud with me, I know other people have done, I know some of you have done this already, but just notice what happens in your body when you say it's over. So say it with me, ready? And notice what happens in your body. It's over.
It's over.
And once more, it's over. And now let's just tweak that. It's over and I'm safe now. Okay, we ready? Observe what happens within. It's over and I'm safe now. And let's just do it once more because it just feels so good. It's over and I'm safe now. And so what we do as TRTP practitioners is we connect heart to heart, soul to soul with the other, with the client. So I've got you. and you're safe. We've got this. All you have to do is follow my instructions, throw all that you are into it, and you can expect extraordinary. I say to a client, why would we return you to normal when this is your opportunity to create extraordinary? Because that's what we do. Some people are asking, is TRTP similar to rapid transformation therapy? Carole.
Yeah, had this question last a couple of months ago. It's similar to a small part of TRTP in that what RTT does, and I've looked at that and done the course myself. It looks at unconscious core beliefs and it recognizes that if you can address and come to terms with and acknowledge your unconscious core beliefs, that can be a powerful transformational experience. TRTP takes it to a much more powerful second stage, and that is not only addressing the unconscious core beliefs, which we do in the first session, but in the second session we then go in to reset the brain around chronic trauma. And you can't really do that. It will certainly not the way that RTT does it. It requires a skilled approach, quite a clever combination of techniques, which is what Judith has done so beautifully with TRTP. And the real power is in that second session.
That's where the rubber hits the road.
Yeah, that's where the rubber hits the road.
That's the therapy.
So that's the therapy. So you get people prepared for it with the first session, which is like RTT. But it's the second session that carries all the oomph, and there's a third session as well. So it's like a kind of a, I think I don't find it anything like as powerful or as sophisticated as TRTP, and I've trained in both. So
yeah, so we turn off those videotapes.
That's just my humble opinion.
Yeah.
Yeah,
no, I agree absolutely.
And the proof's in the pudding, really, just to give an idea of how effective this is. You know, I was talking about that woman with her pain, and there was a normal outcome would be like this. Psychiatrist rang me, he said, I work at this big hospital, I'm a PTSD expert, I run the trauma unit. I've been working with this man with complex PTSD for 9 years, seeing him every fortnight, getting nowhere, hospitalizing him a lot of the time to keep him alive. And he's just left my rooms, and I'm ringing you because I've just witnessed a miracle. I've just seen the impossible. Because in the 2 weeks since I last saw him, he went to one of your students, not even a graduate, a student, had your 3 sessions, and is completely free of PTSD. He's a completely well man. This is a miracle. This is impossible. So I obviously don't know what I'm doing. I better come and learn. But that is normal. If that doesn't happen, we ask why. Joe, is there an element of NLP timeline therapy in TRTP? Would anyone like to talk to that? Dinah?
Yes, there is a little bit. Yes, I mean the TRTP draws from a lot of these related disciplines, and yes, there is a certain amount of timeline therapy. We look at the past traumas, so there's a timeline associated with that, but without having to go back to them. Some of depending on how NLP is done, there is the risk of re-traumatizing because you can end up a little bit too close to it. We have a system within TRTP to make sure that you remain dissociated from that sort of thing. So there's that retrospective kind of timeline stuff. There is also future time, age progression, if you like, when we look in the third session and we're looking at, now let's get together and let's really create what you would actually like to think, why bring you back to normal, as Judith said? Why not move on to extraordinary? And actually that's my favorite part of the whole thing, because I'm an optimist. So I like then to see how people then progress, because you then get this huge domino effect of what else happens once you've seen somebody for one particular thing, say a particular pain problem or whatever it is, or PTSD from something else, that you then, having turned off this stuff that's been going on that is emotionally absolutely exhausting, you then open them up to possibility, and they then start saying, well, actually what I'd really like to do is this, and then a couple of months later you find out that they've moved and they've all these other things have happened, and it's the knock-on effect is enormous.
It's extraordinary in every area of their lives. And the other thing that happens is that the dynamics of our relationships change. Carole, would you like to say anything
Absolutely.
more about the timeline thing?
No, I think you've pretty well covered it. I think that,
Okay.
that the third session is important, and if you listen to people like Joe Dispenza, they'll always say, you know, if you get up in the morning and you're doing the same sort of stuff and you're thinking the same sort of way as you did yesterday, then you know you're not going to be creating your future. So it's all about, let's create the future. Let's just not let the future create us. Let's create our future. So it's understanding the bioplasticity of the brain and saying, we'll fix the trauma, but we'll do more than that. We'll actually take us somewhere that we want to be now, because the past is behind. You know, you're no longer dictated by what's happened in the past. So what are you creating for your future?
Yeah.
It's wonderful. Yeah.
So the similarity is that we ask people to make a list of the 10 to 12 top most distressing events in their life. The age, the name of the event, and who was there. That's it. So we don't go back into the experience, and it is different from timeline.
Judith, someone asked if you don't remember your trauma.
Would you like to answer that?
No, I'm going to ask you to answer that one, actually, because I haven't had anyone who hasn't.
You haven't had anyone who hasn't. Okay, sometimes people don't remember their traumas. I've had several people who come and say, well, I can't remember anything. And the first time I remember was 12 years old. I had one man who couldn't remember anything before 18.
That's a long time.
Something was going on.
Something severe there. Yeah.
Something very severe. So the memory had completely shut down. You don't need to remember a specific event. And just let's get clear, people. If you take away the word trauma and say distressing events, we get more of an idea of what we're talking about here.
Because that brings in the birth things, the cancer diagnosis that people have mentioned here.
Yeah. And
grief is another one.
Yep. And it's not one trauma. Like I have people say, but I don't know what event was the trauma that started my OCD or whatever it is. So there's never one event. The stuff of life, all those different big videotape loops and the little ones builds up until we blow out.
Yes.
So there we are. Still going through here. Okay, so here's someone saying, since going through TRTP, I'm ready for extraordinary. Just beautiful. What if there is chronic pain, which is real, but
Can I just mention one more thing we were saying about the where they can't remember the trauma, where you've got these people who've got, essentially a black box.
Yeah.
I don't remember anything. There's this black box.
Mm-hmm.
It's not necessarily to open that.
We don't. Oh, no.
All. You don't ever open that. You say, okay, that's fine. There's the black box. Can you find the black box? Can we bury it? Can we bomb it? Can we destroy it? Can we set it on fire? Fine, it stays in the black box. Let's destroy it so that nothing can even slightly leak out at any point.
Some people come saying, I want to remember.
Yeah, no.
Why?
Don't
go there, because every memory is a fiction anyway, and it changes over time. So if you go looking for memories, you'll find memories, and they may never have happened. So we don't need to go there. We just have to take that 9-year-old, 12-year-old and make them safe.
Well, that's a
it's
great
over.
Black box.
It's over.
I like that.
And I'm safe now.
Yep.
So you just need to go to that person at that age and do whatever is required. So it's over. And I'm safe now. That's it. It's very, very simple. No. Can you treat couples together? No. Separately. You're not sure I agree with memory may be fiction. In courtrooms, they're proving that that a lineup doesn't work.
No.
Lots of innocent people are picked out of lineups because if you have 20 different people see an event, witness a criminal event, for example, you'll get 20 different stories depending on the perception and the filters through which that person experiences life. Can TRTP also be used to assist those with ongoing pain like rheumatoid or osteo where there is a reason for the pain?
Yes, I'm doing it right now.
Dinah?
Yes. The reason really is that a bit like what I was saying before about how irritable you can be if you're also dealing with past traumas and anxiety from other things. If you are in a depressed or an anxious state for other reasons, then your acute pain, flare-ups from your rheumatoid or whatever will be firstly perhaps even set off by the stress, some other stressful event, or become much more difficult to cope with just because you're exhausted emotionally, you're not sleeping properly or whatever. And so even if there's an acute thing going on, by dealing with past traumas and using this sort of process, you can produce a state where that pain is less bothersome. Or you can start using some of the NLP techniques or some of the other hypnotic techniques where you're looking at reframing it and saying, yes, this is an area where your body is actually healing rather than being flared up. But it depends on exactly what's going on. And you need to know that the flare up or whatever it is also being treated at the same time. But absolutely, you can help people cope much better.
Yes, and in terms of when there is extreme pain long term and the pain takes over more and more of the real estate,
absolutely.
It's an interesting phenomenon that the body and the unconscious believe what we richly imagine.
Yes.
And, if you richly imagine, you've got to wedge a lemon. Come on, do it with me.
Get out the lemon.
Get out the lemon and it's so sour and there's so much juice. I don't know about you, but I'm getting the saliva response. My body has just responded as if that is true, that that's actually happening. Everything that would normally happen if I did that is happening. And we can use this to, our power is extraordinary. I'm sure the word magic comes from the word imagination. We can use this to reduce inflammation. We can use this to even imagine, I've done this with people with terrible pain, is imagine, what color is the pain in your brain? And it's usually red, can I just say, or black. How much of your brain is it taking up? And they say, okay, now change the color of it to something really beautiful and make it smaller and smaller and smaller. I mean, there's a little bit more to it, but basically that's it. And the body and the unconscious believe that's actually happening. I did it myself. I was diagnosed with hydrocephalus and they wanted to start drilling holes in my brain. I thought, no, give me a week. I was having seizures. I said, give me a week and we'll do another MRI and we'll see. And they said, well, that's very dangerous to leave it for a week. When you're at this stage, you might die. So, well, dying's pleasant, but just give me a week. And so I imagined, I got the scans and I imagined that fluid getting less and less and draining back into the spine. And I did that every day. And I told my unconscious and my body, okay, I'm going to work now. Keep doing that. We've got 6 days, 5 days, 4 days. It's extraordinary what we can do. And at the end of it, the surgeon got straight onto the place where I had the scan done and said, there's been a mix-up. My patient has hydrocephalus, this one doesn't. There's a mix-up. Sort it. I said, no, actually, there's no mix-up. So simply use the brain.
I like this actually. I like that comment at the bottom there from Liz. Yeah, absolutely. We have this tremendously powerful brain that we're just not using properly.
Yes.
And why are we using it for evil? It's capable of producing this making, if you like, a mountain out of a molehill sometimes. We can actually use it to reverse that as well. It is that powerful, and it's a question of training you and realizing that you do have this power, and we are underutilizing this brain.
Absolutely. And so what we do in TRTP is we create various scenarios, and the person richly imagines them, just lives the scenario, and the body and unconscious believes that's happened. It's very simple. And in doing that, we move them to an empowered position in regard to what's happened. And then we tell them it's over. I'm safe now. Yeah. And every part of you that had anything to do with that can now return to calm. Feel it.
Yeah.
And Joe is saying, I agree with Dinah, as I've experienced this myself, rheumatoid pain. Go you, Joe.
Excellent.
Thank you, Dinah. There's someone suffering from...
Question there about intergenerational trauma.
Okay. All right, we've just got a few minutes left. Intergenerational trauma. Who'd like to talk about that?
Either of us. You go, Dinah. I'm sure we're going to say the same thing.
Yeah, just in a couple of sentences.
As the daughter of the father
yes,
with PTSD, yeah, I know all about it. Yeah.
Yeah,
from the
look,
war.
absolutely. I think it is important. I think it is important. I think you can, sometimes just recognizing that is enough. Just to be able to say, and I did this with not using the TRTP process particularly, but using somebody as a reframe from who'd got a needle phobia from somebody else. You know, you can take this stuff on. We take stuff on all our lives, ideas and things that come from other people, and the most influential people are our parents. And if they are bringing in intergenerational trauma in subtle ways, they will be influencing as you grow up.
Not even so subtly.
And there's
not even so subtly. No, that's right.
And just because we're about to wrap up, I'll just wrap this up quickly. Sorry, Dinah, to butt in.
Not at all.
It's what I do. Sorry.
But away.
That's why we love you. You're right.
But I mean, the science of epigenetics proves that
absolutely.
trauma is passed on from generation to generation, and we have a process with TRTP which stops that.
So yes,
so that's in a nutshell. That's it. In terms of COPD, I'm looking for it now. COPD. There's something.
Chronic obstructive pulmonary.
Yes. Which is irreversible.
Disease.
How can this treatment offer peace of dying? Some of the most profound work I have done is with end-of-life clients, either from multiple sclerosis or whatever, because what we do is resolve all the pain, all the emotional pain, all the distress of life, and bring that person to peace. And they have a peaceful death. And death, I've died 3 times, and it's really lovely. I'm just saying.
Been there, done that.
Chick. Ask me something hard.
Okay, so we're about to wrap up. I'll just take a couple of minutes to say thank you for joining us.
To peer at the
where's the training? There's some. Okay. Good question. The TRTP practitioner training is an intensive 8 weeks of training. Most of it is online. It begins with the student doing the sessions, working on your own stuff, experiencing TRTP as your future clients will experience it. It's only in doing that that we understand the power and the possibilities of it, and that we can come to the learning to help others clean and clear of our own stuff. You're laughing?
Someone said you must be Greek. I interrupt as well, she says.
Oh, I like that. No, Irish and I'm a
Greek ladies are coming back to you.
Yeah. And then there's a 3-day workshop online. So you do those sessions with your mentor. Everyone gets a mentor. The care that each student experiences, because everyone's assigned a mentor, a senior practitioner who basically holds their hand through the training. The face-to-face part is a 3-day workshop at University of Queensland in Brisbane. We used to go all around the countryside. We don't anymore, because everywhere we went, only 10% of the people would be from that city. So we thought, well, let's stay home. So people are flying in from, we've got someone coming from Zurich, I think, in this next one. We've had people from South Africa, Holland, all around the place. But so there's a 3-day workshop. After that workshop, you go and work with your own clients. We say, have clients ready to go, and your mentor will hold your hand through your initial clients. And for the next 5 weeks, there's other training online, a 2-hour video conference call with me where we build on the training that you've already had. So at the end of that 8 weeks, you don't just have knowledge, you don't just have information, you have real experience with clients. You have runs on the board and you know what you're doing. But we don't leave you there. Because after that, you go into our TRTP practitioner community, which is one of the best bits. This is a warm, extraordinary, smart, amazing community where the ethos, the culture is one of kindness, generosity, and mutual support. The support is second to none. There's a video conference call each week where we all get together, and there's a forum online where people can get just about instant assistance with a tricky client, a tricky case.
Yeah.
So the next one is in August. In August with the 3-day workshop, the 16th to the 18th of August. There's another one in September with the 3-day workshop, the 4th to the 6th of October. The reality is we can't keep doing what we're doing. It's not working. The cost is going, I mean, Carole's talking about $26,000 per mental health work cover.
And another study that came out of the Australia Institute in 2018, I think, they did a whole paper on the cost of trauma and stress to Australian society. In particular, they were looking at first responders, but their analysis, cost-benefit analysis, was for any intervention up to about $15,000 was considered to be a cost benefit. Over and above that, it wasn't, but that's the basic cost. Up to $15,000.
So when you can do something in 3 sessions for $1,000, $1,200, $1,500, it's looking good.
And if anyone out there, can I just say, please,
sure.
My goal is to try and get eye care and work cover eye care in New South Wales to take a look at this. And I feel like sometimes I'm just, talking into the void. But if anyone out there has got any contacts or assistance or ways of getting the ear of the mental health team at iCare, I've tried. I'd really appreciate that.
And Carole can be contacted through the practitioner directory on the website, the richardstraumaprocess.com.
I'm trying to save the money.
Yes, and let's talk about that. There's more than just the financial cost.
Absolutely.
There's a tsunami of physical and emotional pain out there, and what we're using is not effective enough, and we're just on the tip of it. It is going to get worse. I mean, you've got the generational trauma. I mean, look at what happened last century. It's coming through. It's snowballing. We have to do something different, something effective and safe and fast and cost effective and long lasting. And this does it. So if you're interested, our end point is simply to change how mental health is done. We have our own research teams in place. We're about to release our first audit of 717 clients. The results are extraordinary. Stay tuned for that. We also have people like Dr. Rosemary Boone doing EEGs before and after TRTP to show the change in brain function. So that is coming. If you would like to join us, because what we're doing, it's a revolution, can I just say. We're getting contacted from people all around the world saying, bring this. How do you hear about it? Just because it works. We have to do something. If you are called, if this compels you, go to the website, the richardstraumaprocess.com, go to the training page, the training is explained there, and click on the Q&A, make an appointment to speak with us, and we'll answer all your questions. If you're looking for a practitioner, go to the practitioner directory on the richardstraumaprocess.com. There are practitioners, there's about 200 practitioners now around Australia.
It doesn't have to be done face-to-face.
Good point, Carole. It's just as effective online.
We do it like this.
Yeah, that's
right. With a headset on.
In fact, we've been doing it while we've been talking to you.
That's right. You didn't even know. I've done it by phone. Not even video. I can do it by phone now. So, those people who find a computer challenging.
Or can't leave the house.
Yep. Which reminds me, I have to go. I
Yes.
actually have a client now, so I'm going to go.
Yeah.
Thank you, Dinah. Thank you, everyone, for joining us.
Thanks, Dinah.
And
Gotta run.
bless you all.
Take care.
Thanks.
Thank you.
See you next time. Bye. Have a good evening.